Hello, good afternoon. God bless you, everyone. Let's begin with our today's topic of discussion, atrial fibrillation. The main points that we are going to focus in today's presentation would be epidemiology of atrial fibrillation, morbidities associated with this arrhythmia, how to diagnose atrial fibrillation, certain risk factors that are responsible for the condition, classification of atrial fibrillation, and we will also discuss the elaborated management about the risk of stroke, thromboembolism, rate and rhythm strategies, and recommendations about the lifestyle modification, as well as at the end, we will discuss about the few scenarios in special situation. We know that atrial fibrillation is the most common sustained arrhythmia, where the global prevalence of this arrhythmia is about 50 million, reported in 2020. According to Asia Pacific Heart Rhythm Society, the prevalence of atrial fibrillation in Asia Pacific countries varies from 0.49% to 5%. And we can see the greater prevalence of this condition in those who are elderly. Why atrial fibrillation is an important arrhythmia? Why we need to identify the condition? Yes, because it is associated with a lot of morbidities. It increases a 5-fold risk of heart failure, 2.4-fold risk of stroke. There is also increased risk of chronic kidney disease, increased risk of myocardial infarction, peripheral arterial disease, and without any doubt, it also increases the risk of sudden cardiac death, that is by 2-fold. Okay, let's come to the diagnosis, the electrocardiographic criteria for atrial fibrillation. Atrial fibrillation is characterized by disorganized, uncoordinated atrial activation, and that is responsible for loss of P wave in the ECG. As I have pointed an arrow in my ECG, we can see these are the bizarre pattern. These are known as the fibrillatory waves, the F waves. We don't see any discernible P wave. Plus, there is an irregular RR interval. This depends upon the AV conduction. It can be a fast ventricular conduction, and it can be a slower ventricular conduction. Coming towards the risk factors that are responsible for the condition and the classification of atrial fibrillation, we will first go through a scenario so that we can easily grip up and gel into the further coming information. The 65-year-old retired teacher is on regular medication for hypertension and hyperthyroidism from last 5 years. She is complaining to you for palpitations and feeling of fatigue during her daily walks around the neighborhood, and she visits us now with a current episode of palpitation that has lasted from last 20 minutes. She has never smoked, but she is a social drinker. On examination, you have found an irregular heart rhythm, and her ECG is consistent with atrial fibrillation. Now, we are going to identify the risk factors and classify her atrial fibrillation. Briefly, according to this scenario, if I point out that she is an elderly female who is suffering from hypertension, she is hyperthyroid, plus she is occasional drinker. So these 4 risk factors add her or increase her risk of atrial fibrillation. If we classify her atrial fibrillation, as I would discuss in detail in the coming slides, this atrial fibrillation has lasted for about 20 minutes. Plus, she is having previous episodes of palpitations as well. So, according to the classification of atrial fibrillation, she is having paroxysmal atrial fibrillation. Now, when we come to the literature review about the risk factors, we see that there are many modifiable as well as non-modifiable risk factors that have been proposed that increase the risk of atrial fibrillation. Modifiable risk factors include hypertension, diabetes, obesity, hyperthyroidism, smoking, and alcohol consumption. Excessive alcohol consumption is categorized as more than 50 units per week of alcohol in a female, and more than 35 units for a male, and more than 35 units per week for a female. Non-modifiable risk factors like advanced age, presence of heart disease, that may be a coronary artery disease, a valvular heart disease, congenital heart disease, presence of systolic or diastolic LV dysfunction. Certain other modifiable risk factors like chronic kidney disease, family history, sleep apnea, and the inflammatory conditions, they all increase the risk of atrial fibrillation. In 2023 guidelines of atrial fibrillation by AHA, novel risk factors have been suggested. They also increase the likelihood or risk of atrial fibrillation. These risk factors are raised B-type natriuretic peptide, raised level of CRP, interleukin-6, interferon alpha, lipoprotein A, presence of left ventricular hypertrophy on electrocardiogram, presence of dilated LA on transthoracic echo, increased LV wall thickness, and increased resting heart rate. When we come towards the classification, atrial fibrillation is classified as a patient may be at risk of atrial fibrillation, patient may be pre-AF, and patient may be in atrial fibrillation. At risk of AFib would be those patients or that population who are having the certain risk factors for atrial fibrillation, like a patient who is hypertensive, who is obese, who is hyperthyroid, is at risk of atrial fibrillation. Pre-AF AF are those people who are having some structural abnormality or they are having some electrical changes. The structural abnormality, as I have discussed with the novel risk factors, is presence of increased LV wall thickness on transthoracic echo, dilated left atrium. The electrical changes can be the more frequent atrial ectopics or more frequent bursts of the atrial tachycardia. A patient who presents to you with an episode of atrial fibrillation is categorized into paroxysmal AF, persistent AF, long-standing persistent, and permanent AF. Paroxysmal AF is the one where atrial fibrillation has not lasted for more than 48 hours, or it has reverted spontaneously without any need of cardioversion or any need of the drugs or any therapy. Persistent atrial fibrillation is the one that has lasted for more than 7 days, or the patient needs your help. It may be in the form of a cardioversion, drugs, or whatever. A long-standing persistent is the one where atrial fibrillation has lasted for more than 1 year. Permanent atrial fibrillation is actually the point where the treating physician and the patient, they have accepted the condition and they give up any further efforts to revert the arrhythmia. In 2023 guidelines, the highlighted points for management of atrial fibrillation, they have proposed 3 pillars for the management. First pillar is to assess and treat the risk of stroke. Second pillar is to optimize the modifiable risk factors. And third pillar is to reduce the AF burden. We will come towards these management points after coming through this scenario briefly so that we can merge into all the recommendations. A 68-year-old female presents in emergency with complaint of palpitations from 2 days and she is feeling dizzy from last 2 hours. She is obese, she is hypertensive, and she's also having hyperlipidemia. On her presentation, she is in hypotension, her pulse is feeble, and her electrocardiogram is suggestive for atrial fibrillation with rapid ventricular response. Now, how we are going to manage her immediately in emergency as she is in hypotension? What would be the possible complications if we not address her immediately, and how can we modify her risk factors? The initial presentation of the patient depends upon the hemodynamics. We will assess the patient's hemodynamics as in the case scenario, patient is in hypotension. Therefore, in such a scenario, the class 1 recommendation is to go with direct current cardioversion. That should be a synchronized cardioversion, and it has been said in the guidelines that if we start with the greater energy, say more than 200 joules, the chances of reversion to sinus rhythm are greater. The second thing would be to see whether the patient is in pulmonary edema or not. If a patient is in pulmonary edema, patient is significantly short of breath, again, the direct current cardioversion would be the class 1 recommendation. If the patient is hemodynamically stable, patient is not in heart failure, then you can go with the pharmacological cardioversion. And for that purpose, IV amiodarone is a class 2B recommendation. Even if you have decided for the rate control in acute setting, we can go with the beta blockers and calcium channel blockers. Now, what to do with the patient in the long run? We need to consider a certain variables that how we are going to manage this patient in the long run. The class 1 recommendation about the long-term management about the heart rate control is the shared decision between the treating physician and the patient. We have to take into consideration the clinical presentation, comorbidities, medication profile, and patient preferences so that we can opt whether we are going with the rate control or rhythm control strategy. These variables, apart from the patient's decision, would be patient's age, previous history of atrial fibrillation, what is the AF symptom burden, what is LA size, patient's LV function, and presence of any AV regurg. The factors that favor rhythm control over the rate control would be a young patient who is having shorter history of atrial fibrillation, more symptomatic, small LA size, greater LV dysfunction, or presence of any AV regurg. These variables would favor the long-term rhythm control strategy. Now, what to do when you have chosen for the long-term rate control strategy, and what to do when you have chosen for the long-term rhythm control strategy. If we go with the long-term rate control strategy, the first thing to assess is the patient's LV function. If patient's ejection fraction is more than 40%, we can go with the beta blockers and non-dihydropyridine calcium channel blockers. Use of digoxin in such a scenario is a class 2A recommendation. In a patient who is having LV dysfunction, let's say less than 40%, at that time, beta blockers would be recommended. Use of non-dihydropyridine calcium channel blockers like diltiazem or verapamil in such a situation may be harmful to the patient. Now let's go to the long-term rhythm control strategy. It would be opted, as I have said previously, in a patient who is having significant LV dysfunction, there is more symptom burden, and patient is having some valve regurg. In such a scenario, this is the class 1 recommendation. Therefore, when we go with the rhythm control strategy, we assess the presence of LV dysfunction. Greater LV dysfunction, rhythm control strategy. If the patient has not opted for the rhythm control strategy, or the patient was not having symptoms of heart failure, then definitely this is a shared decision between the patient and the treating physician. Options that can be used for the rhythm control are antiarrhythmic drugs, catheter ablation, and even surgical management. Use of antiarrhythmic drugs like doftilide, ronitron, flecainide, and propafenone is a class 2A recommendation. An important thing to note is that catheter ablation for the purpose of rhythm control in a patient with atrial fibrillation has been upgraded from class 2A to class 1 in these 2023 guidelines of atrial fibrillation. And they have been proposed when the patient is having ineffective antiarrhythmic drugs. Use of surgery for control of or maintenance of the rhythm is a class 2A recommendation, especially when a patient is going for some other cardiac surgery. This is an important slide to consider because now you have to choose an antiarrhythmic drug depending upon the presence of patient's LV, patient's structural heart disease. It can be a valvular disease. It can be a wall motion abnormality. Those patients who are not having any structural disease, they we can use doftilide, ronitron, flecainide, and propafenone. However, in the presence of structural disease, the better drugs to use are amiodarone and doftilide. We need to avoid ronitron, we need to avoid flecainide as well as propafenone in such patients. They may be harmful in presence of structural heart disease. Coming to the second pillar of the management of atrial fibrillation, that is the risk of stroke or thromboembolism. We have to use the validated clinical risk score, that is the CHADS-VASc score. The variables that are used in the CHADS-VASc score are patient's age, gender, hypertension, diabetes, presence of congestive heart failure, any previous thromboembolic event, or presence of vascular disease. All these variables are given 1 mark, except for the greater age, more than 75, and presence of stroke. They are given 2 marks. A patient is said to be at high risk of thromboembolism. It means annual risk of thromboembolism is more than 2% when a patient has CHADS-VASc score of more than 3 in a male and more than 2 in a female. Another important thing to remember is that we need to anticoagulate any patient on the basis of CHADS-VASc. It is not on the basis of the pattern of AF. So a patient who is having paroxysmal, persistent, long-standing persistent, or permanent AF, he should be anticoagulated provided that CHADS-VASc score is high. So in the given scenario, as I have discussed previously, the patient was having paroxysmal AF, but we have to anticoagulate that patient because the CHADS-VASc score is higher. Now, we have decided to anticoagulate a patient on the basis of CHADS-VASc. What to do? What anticoagulant you are going to choose? The preferred drugs are direct oral anticoagulants, except when the patient is having more than moderate stenosis or patient is having mechanical heart valve. Apart from these 2 conditions, every patient will be given direct oral anticoagulants. Direct oral anticoagulants can be factor Xa inhibitors like rivaroxaban, apixaban, edoxaban, and it can be a direct thrombin inhibitor like dabigatran. Okay, the second point to remember is that, and that has been upgraded in the newer 2023 AHA guidelines of atrial fibrillation, is that we don't use aspirin either alone or in combination with clopidogrel for the purpose of stroke prophylaxis. So we don't use aspirin for the purpose of stroke prophylaxis. Need of cardiac surgery for the purpose to reduce patient's risk of stroke is a class 1 recommendation where the patient's CHADS-VASc was higher. So again, you go for the surgical LA appendage occlusion just on the basis of CHADS VASC, and that would be done not in a routine, but only in those patients who are going for some other cardiac surgery. While you're giving the anticoagulants to the patient, you need to know the safety of anticoagulants as well. And for that purpose, we have established validated risk score estimation, that is the HAS-BLED score. The variables are hypertension, abnormal renal and liver functions, presence of stroke, bleeding tendency, labile INR, elderly, use of the drugs or alcohol, like use of non-steroidal anti-inflammatory drugs or antiplatelets. All these variables carry 1 mark. A patient is said to be at higher risk of bleed when the patient's HAS-BLED score is equal to or more than 3. So at that time, you need to be on toes when you're giving the anticoagulant to such patient. So this is a recommendation that any patient who has been given anticoagulant or DOACs when he falls into the moderate risk category, the risk estimation should be done every 6 monthly. Whereas if you are giving anticoagulant to any patient who is at high risk of bleed, the risk re-evaluation must be done every 3 monthly. What to do when you are giving a patient anticoagulants and patient starts bleeding? You have to evaluate the patient, whether the patient is having minor bleed, non-life-threatening or life-threatening bleed. Minor bleed is the one where you can have the bruises or a small epistaxis in a patient, otherwise the patient is hemodynamically stable. In such a condition, just with holding the anticoagulant and going with the supportive measures can be enough. But in case of life-threatening bleed, where there is fall of hemoglobin by more than 2 grams per deciliter, or you need blood transfusion more than 2 units, such patients will require the antidote of the given anticoagulant, apart from giving the patient supportive therapy in the form of prothrombin complex concentrate or in form of fresh frozen plasma. The recommended antidotes for the factor 10A inhibitor is antaxinate alpha, and for dabigatran, it will be idarucizumab, where in case of warfarin, this is IV vitamin K. Coming towards third pillar of the management of atrial fibrillation, that is the modification of the modifiable risk factors. So a patient who is obese is recommended to lose at least 10% of the weight so as to reduce the symptom burden, recurrence, and progression of persistent atrial fibrillation. A patient who is having a sedentary lifestyle should target 2 to 10 minutes per week so as to reduce the risk of atrial fibrillation. A patient who is having excessive alcohol or smoking must abstain or at least try to reduce his alcohol or smoking. Patients who are hypertensive or diabetic should try to gain their optimal blood pressure and blood glucose control. An interesting recommendation is about the caffeine abstention that we are doing routinely in the patients who may be at risk of atrial fibrillation. So this is a class 3 recommendation in 2023 guidelines that caffeine abstention is not recommended just to prevent an episode of atrial fibrillation, but however, it can be given, can be suggested when a patient is already having atrial fibrillation to reduce the patient's symptom burden. Coming toward the certain interesting scenario, which can give the challenges in management of atrial fibrillation. A 72-year-old diabetic male with previous history of PCI to LAD and ejection fraction 45% presents to you in emergency. He is feeling discomfort and palpitations from last 3 days after suffering an episode of upper respiratory tract infection. On examination, you note that his pulse is irregular, but he is vitally stable and his chest is clear. His hemoglobin is 9.5 and his creatinine is 2.8. What is his risk of stroke? Definitely, as discussed previously, according to CHADS VASC, his risk is high. Patient is having reduced ejection fraction, he is a male, he is diabetic, and he is having previous history of PCI to LAD. Patient's risk of bleed would also be higher because if we take into consideration the HAS-BLED score, definitely he is having D-range RFT, so he is at least into the moderate risk category of bleeding. The most important challenging situation in such a patient would be how to manage the anticoagulation. We know that he is high risk for moderate risk for bleed, but he is high risk for thrombosis. He is already on antiplatelet therapy. So the recommendation in such a scenario are that patient must be given anticoagulant, and the preferred anticoagulant in such a situation would be direct oral anticoagulant, and that must be given, or the triple anticoagulation will be given for at least 4 weeks. After 4 weeks, we need to stop patient's aspirin, and we will continue with the P2Y12 receptor inhibitor and the anticoagulant. That anticoagulant, of course, would be the oral anticoagulant preferably. Coming towards some more interesting scenarios, you have a 75-year-old male with history of heart failure, currently in NYHA class 3, and suffering from atrial fibrillation. He comes to you in emergency department, and he is severely short of breath. He is having chest pain, and he is also in hypotension. He is tachypneic and diaphoretic. His ECG suggests atrial fibrillation with rapid ventricular response. So what should be the initial management? Definitely, the patient, as we have discussed previously, patient is in hypotension, he is in shock, he needs direct current cardioversion. That should be a synchronized and at more than 200 kilojoules. How can we minimize this risk of thromboembolism? Well, the recommendation is that we need to give him anticoagulation, that pericardioversion as well as post-cardioversion. So what are the recommendations? The post-cardioversion anticoagulation in a patient must be a DOACs, and it should be given to the patient for at least 3 to 4 weeks. After 4 weeks, you have to reevaluate the patient by doing the transthoracic echo and looking for presence of any intracardiac thrombus. If there is no thrombus, yes, you can stop your anticoagulant provided your patient maintains the sinus rhythm. If patient is having any thrombus, we will need to further continue with the anticoagulation. Okay, the last point in this scenario was, what is the recommendation about catheter ablation? If you remember, in my previous slides, I have focused that in the updated guidelines 2023 that has been proposed by AHA, the catheter ablation has received class 1 recommendation in the patients of heart failure, preferably when the patient is having a high symptom burden, and therefore the catheter ablation will be recommended in such patients to improve the symptoms, improve the quality of life, ventricular function, and other cardiovascular outcomes after a trial of antiarrhythmics. Coming to another interesting scenario, we have a 35-year-old male who is a known case of WPW, and he now presents to you in emergency with complaint of palpitations, and otherwise he is hemodynamically stable. This is his ECG. As you can see, there is atrial fibrillation with rapid ventricular response, and the arrow points towards the antegrade conduction over the accessory pathway. We know from our previous knowledge that such a patient would be high risk for any type of ventricular arrhythmias. How we are going to manage this patient in emergency, and how we can reduce his risk of further arrhythmias. So the recommendation in such a patient would be, if in this scenario, the patient is hemodynamically unstable. So we will go with the pharmacological cardioversion, where the preferred drug is IV ibutolide and IV procainamide. Provided he was not hemodynamically stable, we would have gone with the electrical cardioversion. In the long run, to reduce his risk of further AF episodes, we definitely need to go towards catheter ablation of the way. An important thing to remember is that in the patients of WPW who are having atrial fibrillation with the antegrade accessory pathway, the use of AV nodal blocking drugs, that is amiodarone, adenosine, beta blockers, calcium channel blockers, is contraindicated because they increase the patient's risk of ventricular arrhythmia. This is another interesting scenario. Here, your patient is a 55-year-old male who is a known case of hypertrophic obstructive cardiomyopathy, and he comes to us with complaint of palpitations and fatigue, and his ECG confirms the presence of atrial fibrillation. What are the recommendations about control of heart rate and anticoagulation in a patient with HOCM? So the class 1 recommendation in a patient with HOCM and AFib is to go with anticoagulation regardless of the CHA2DS2-VASc score. This is an important point to remember. You don't go with the CHA2DS2-VASc scoring in HOCM. In any other patient, you are going to doing the CHA2DS2-VASc scoring for estimation of the thromboembolism. But in case of HOCM, even if your patient is subclinical, you need to anticoagulate your patient. The second important thing, how you are going to control the rate of rhythm. The class 1 recommendation are the beta blockers and calcium channel blockers. We need to remember that we don't prescribe Rapamil to such patients who are having the higher resting gradient of more than 100 millimeter of mercury. Rhythm control will be preferred in such patients, and that can be by means of the amiodarone. You need to remember that disopyramide is not used in patients of HOCM suffering from atrial fibrillation for the purpose of AF control, but it would be given to the patient for the purpose of reduction of LV obstruction. Now, another scenario, we have a 30-year-old pregnant female who is at 20 weeks of her gestation, and she comes to us with complaint of palpitations and shortness of breath. She also has previous history of paroxysmal atrial fibrillation before pregnancy, but she has got more frequent episodes since she has become pregnant. How you are going to manage this patient? She is having frequent episodes of paroxysmal atrial fibrillation and she is pregnant. Well, the recommendations are you go with the rate control in pregnant patient with structurally normal heart, and you can use propranolol, metoprolol, even digoxin. Restoration of the sinus rhythm with use of antiarrhythmics like procainamide is a 2B recommendation. For anticoagulation purpose, we will calculate her Charles-Vasc score, but the choice of anticoagulant won't be DOACs. That would be a vitamin K antagonist. Provided the patient was hemodynamically unstable, we would have gone with the direct current cardioversion. So direct current cardioversion is safe in a patient who is pregnant presenting to you in atrial fibrillation and hemodynamically unstable. Now we briefly discuss the management of atrial fibrillation in some other systemic illnesses. In a patient who is hyperthyroid, treatment of the underlying cause would be your main goal, while management of atrial fibrillation be as per the general guideline. We can go with the rate control by using non-dihydropyridine calcium channel block. If the patient is having some compelling indication, like patient is suffering from MI or patient has heart failure, we can go with the cardioselective beta blockers. Rhythm control strategy has been proposed in the patient who are suffering from pulmonary hypertension. It is the class 1 recommendation. Now, let's conclude our discussion with some take-home messages that AF is a disease continuum. It requires a variety of strategies at different stages, from prevention, lifestyle, risk factor modification, screening, and therapy. AF risk factor modification and prevention is a pillar of management. Early rhythm control is preferred, but only after shared decision-making. Catheter ablation of atrial fibrillation is appropriate in patients with heart failure, and it has gone to the class 1 recommendation rather than from the previous 2A recommendations. It is the Charles-Vasc score and not the duration of AF that decides the need for anticoagulation. Use of aspirin for prevention of stroke alone in AF is a class 3 recommendation. Any patient of HUCM who presents to you with atrial fibrillation must be anticoagulated independent of the Charles-Vasc score. This is all from my side. Let's go towards Dr. Ali Hassan so that we can have the input from our expert panelists. Thank you very much.
Thank you very much for such a comprehensive talk. I think it was a great task that was given to you to summarize all the important aspects from classification, management, from stroke prevention, and to management of even anticoagulants and management of the arrhythmia in various circumstances and comorbidities. Before I proceed for the comments from the panelists, I need Dr. Azmat to introduce Professor Wajid from Royal Brompton University, United Kingdom. He is also an electrophysiologist. Further, before he introduces you, I would like Dr. Azmat, along with Dr. Wajid, especially to focus their comments on catheter ablation being an early intervention for AF, its importance, and how can we implement this in our setting in the developing country. And also, I need you guys to focus on the new era of artificial intelligence and AF being detected silently, and how do we manage it? Over to you, Dr. Azmat.
Assalamu alaikum. Thank you so much for giving us this opportunity. It was just a chance that one of our colleagues from Royal Brompton, very competent and very
What happened? You disappeared? Hello?
Asrat, we cannot hear you and we cannot see you as well. Okay. Before you are back, I would move on to.
Sorry, can you hear me now? Can you hear us?
So I think you can hear you.
Yeah, I can hear you.
Okay, so I'll
Great.
ask one to have his comments first. And being a very top-notch electrophysiologist and an ablator of AF in all forms of atrial fibrillation, be it paroxysmal, persistent, and obviously more than that. So I'll hand over to Dr. Wajid to give his comment first. With your permission, Professor Mansoor sir, I hope you won't mind.
Please, please.
So
Please, I'm look forward to learn something today.
Thank you very much, Dr. William. That was a really good presentation. Thank you for that. I think what I would say is for the colleagues here is AF has become very different over the last 10 years. Our thought process behind it has changed. It's become much more like angina. We understand it's a lifestyle disease and that lifestyle is really important. And the primary purpose of it is to control symptoms. We know that it's progressive. So once you have atrial fibrillation, the chances are you will progress almost inevitably to more and more AF, eventually persistent AF. How long that takes you is variable, but there is no doubt that the majority of patients who have paroxysmal AF without a clear trigger will end up in persistent AF. And the earlier you intervene, the better the outcome. It's the same as angina. You know, if you let angina go, don't think about risk factor prevention. It'll get worse and you'll have a problem. The same thing I would say for AF. So what you need to do is take the same aggressive lifestyle risk factor modification approach. You need to think about the patient in the whole round complexity of their lives, and you need to offer them intervention. And in terms of intervention, what I think is increasingly clear is that AF ablation is fantastic at symptom control. It doesn't necessarily prolong your life, except maybe in heart failure, but it undoubtedly has a massive reduction in symptomatology. And compared to drugs, patients prefer it, right? And they find better outcomes. There are multiple trials of drugs versus ablation, and almost all of them, you know, favor AF ablation. So, and the meta-analyses are all very, very clear. So what I would say is, think of this like angina. It's a lifestyle problem for which there is a clear, well-evidenced interventional treatment, a bit like stenting, which again, as long as you know the pros and cons, can be very, very useful. And it is all about shared decision-making. But I think our threshold for AF ablation in the UK and in the Western world has dropped very dramatically. We're almost offering it first line now. You know, people come, they say, I don't want beta blocker, we go, okay, AF ablation. And it works very well if you treat people early. If you wait until right at the end, when they're in a bad way, their left atrium is massive, you know, they've been in there for a long time, then unsurprisingly, it doesn't work. So,
yeah. Over to you, Dr.
Thank you very much, Dr. Wajid, for your valuable comments and your presence in our webinar. And now I will move on to Professor Mansoor for his comments regarding this session. So, his important highlights.
You are breaking, Dr. Aliasan, you are breaking.
Yes, am I clear now?
Yeah, that's better.
Now it's your turn to give your valuable comments and also highlight and focus if how can we move ahead and implement this possibility, and that if we have early intervention for AF, we can prevent and we can decrease the burden of the disease, and also we can have patients lesser likelihood of developing the cardiomyopathy that is going to occur or early dilatation. How can we implement in our part of the world this intervention if we even lack good drugs to control it? What are your comments and what can we do about it? Professor Mansoor, I need your comments on
Yeah.
this, please.
Yeah, I think this is again, as Dr. Wajid has pointed out, this is the commonest arrhythmia that we see in our society also, and it's increasing with the increasing age of the population. It's bound to increase further. And ablation is the most desirable treatment. In fact, if I were to have it, I would prefer ablation rather than sticking to so many medications. But there are issues with that also. The data is there and the data is increasing. But at the same time, in our part of the world, we have got some good electrophysiologists. Professor Azmat is there himself, and we have quite a few in Karachi. And I assume, although I don't do the procedure myself, I assume that the procedure is not as tedious as it used to be at one time. All you have to do is ablate certain parts, and it worked. And I remember seeing surgeons at one time doing MACE procedure for this. But I think we need to educate our physicians as well as our patients. It is possible, it is feasible, it is doable. The only problem is that medical profession itself, regretfully, I have to say that medical profession itself has to be convinced of the usefulness of this procedure, because many of us, usually people like me who do not do the procedure, we do not even recommend to our patients. And I think we need to educate ourselves, the cardiologists, because all AF patients are not seen by electrophysiology, they are seen by physicians or general cardiologists. We need to educate that way. Now, before I finish, I would like to put a question myself. I've seen mesenteric embolism and gangrenes and whatnot. I would like to see, or I would like to hear from somebody, if there is any data which in patients in acute abdomen, which or acute abdominal pain lasting for a short time disappears. Is it possible that it's like a TIA in the abdomen? Because it has always intrigued me. What is the incidence? What is the prevalence? If anybody has the answer to that, please. I hope I have, I'm audible. Hello? Hello?
Hello?
Hello?
Oh, so I think, there's no data that I'm aware of looking at the incidence of embolism in acute abdomen from AF. But what I can tell you is that we get a lot, especially in patients who've been hospitalized in ITU. They often get kind of abdominal ischemia. We've seen many, many patients with splenic infarcts. So, it's not surprising if you're going to get thrombus in the left atrium. It can go into the brain, into the coronary arteries, into the splenic arteries and the mesenteric arteries. So it's all possible, especially if there's systemic upset and the coagulation system is kind of disordered. But I'm not aware personally of any particular data looking at that, but we know it's not uncommon. I've seen multiple cases of abdominal
Thank you so much. Yeah, because in our part of the world, I guess people don't even think about it. There may be minor abdominal pain, acute pains, which disappears in 2 hours, 3 hours, 4 hours, and people go home. I wonder if there is a way we need to formalize in our society. This should be looked into regularly, because with AF or even with paroxysmal AF, if we can have a stroke, we can have acute abdomen. Of course, that's what has always puzzled me, because I haven't heard anything in our society. Whatever I saw was actually in UK during my time in UK. Over here, I've hardly ever heard anybody talking about it. So that's why I was wondering. Thank you so much. Thank you.
Thank you very much,
Yes.
for the importance of highlighting that AF can cause thromboembolism to anywhere, and all symptoms that can be related should not be ignored, and also highlighting the importance of moving on and to understand that there are interventionists who can perform ablation and not only drugs as their only solution. Now, I can see Dr. Ali Fareh from RIC, Rawalpindi Institute of Cardiology. Dr. Ali, can you simply highlight a few new research on the topic and how artificial intelligence and how the detection of atrial fibrillation, if it does not show any symptoms, the device detected atrial fibrillation. How is it important, and what are the new areas of research going on? Any comments on that, and any other comments that you want to add into what has already been talked about?
Sir, are you able to listen? Can you hear me?
Yeah.
Okay. So, Sir Esteem, thank you for the opportunity to express my opinion on this forum. And I would like to congratulate Madam Sania for such a nice and comprehensive presentation. I still remember it was, I think, 8 years ago when I dealt with my first patient who had, at that time, he had a mechanical valve and he came to us for PCI. And it was, I think, 2016, and there was dearth of data regarding the management of antithrombotics for such patients. And the only trial I was able to find was the VOICE trial, which was with the VKA. And now, just 8 years later, we have those 4 pioneer trials like Pioneer itself, the Redual PCI, Entrust, and Justice. And now we can safely say that we started like 10 years back, we were like to continue with triple therapy for 1 year or at least 6 months. And now all the recent guidelines, including the ACC as well as ESC, they recommend and triple therapy with aspirin, with a P2 Y12 inhibitor, and nightly DOAC for 7 to 30 days. And then we have the dual therapy for 6 months to 12 months, and then a single anticoagulant with full dose is recommended after 1 year. That was the higher trial. So definitely in this regard, we have achieved a lot in the last 10 years. And that first question which I had like 10 years back in managing that patient, now we have that bulk of data to support our management strategy. Recently, we also have, there was a study, I think it was Boston's Stewart, and it was from Redual PCI. And if I'm able to show you, there was a very nice algorithm for selecting patient who had, so this was the score, and it was a nice, I hope you can able to see the picture.
Yes, thank you.
So, okay, so this was a score that was taken up from Redual PCI. And so this further categorized the patient who required triple therapy versus those who required dual therapy. So included factors like EF, case of triple vessel disease, MI as an index procedure, or PCI, history of peripheral arterial disease, thrombocytosis, and nephropathy. So more the risk factor, as the number of risk factors increase in this patient, there's more likelihood that the patient will require a triple therapy for longer duration. And the study did not see how long this triple therapy should be continued. But if the factors, if thrombotic risk is high, then triple therapy may be beneficial in preventing the ischemic endpoints. So with this, I hand over to Sir Ali San